Pediatrics. So hello everyone, let's start the pediatric session today, okay, for Krok 2. So today I'll rapidly revise all the topics of Krok 2 exam for pediatrics. Okay, so I've made I've already taken a lecture on pediatrics, but it didn't record well. Okay, so we mistakenly recorded it without voice, so that's why I'm doing it again. Okay, so pediatrics. So we'll start with neonatal parameters. Okay, neonatal parameters. So before starting neonatal parameters, let us discuss this live chat. Okay, I'll start it. So my voice is clear, right? Can you please put a thumbs up if my voice is like I'm audible properly? Just put a thumbs up if my voice I'm clearly audible. Hello. Just give me a second. Okay, we'll start. Okay, let's start. Okay. So before starting neonatal parameters, we'll just quickly go through what is a neonate. So neonate is any child having a lifespan of less than 28 days. Okay. So a neonate is usually any child before 28 days of life. Okay, of life. We call a neonate. And what is an infant is any child having. So any child during first year of life, we call it as infant. So why is it important to know about what is a neonate, what is an infant? Okay. So in Krok 2 questions, we have got some questions like a pediatrician is calculating some pediatric infant mortality rate. Infant mortality rate. Okay, and Then they've asked like which children they usually need to check. Okay, so all the children before 1 year of life. Okay, so that's why this infant word, you should know that any infant is any child during his or her first year of life. Okay, so let us start with neonatal parameters. Neonatal parameters. Okay, so the most important parameters we should be knowing about these four. Okay, so length. So I'll tell you the normal neonatal parameters. So the length of a newborn is 50 centimeters. Birth weight. Okay, so birth weight of a normal child is usually 2.5 to 4 kgs. And now, why do we need to know these normal parameters? Is there are some pathologies related to that. Okay, so let's say I've told you normal birth weight of a child should be 2.5 to 4 kgs, right? If the child's birth weight is less than 2.5 kgs at a term pregnancy, right? At a term pregnancy means the child is born between 37 to 40 weeks of gestation. During this period of gestational life, the child is delivered. Okay, so if the child at term pregnancy is less than 2.5 kgs, we call it intrauterine growth restriction. Intrauterine growth restriction. Okay, so intrauterine growth restriction means that the child was normally developing. If a child is normally developing in uterus, the child's weight should be 2.5 to 4 kgs. But if there's some intrauterine growth restriction, the weight of the child will be less than 2.5 kgs. And in the Krok question, they have asked about the reason for intrauterine growth restriction, and the most important reason for intrauterine growth restriction is chronic placental insufficiency. Chronic placental insufficiency. Okay, so what is this chronic placental insufficiency? Is, see, let's say this is mother's body, right, and this is a developing fetus. So this fetus takes all of its nutrition from mother's body via placenta, right? So if there's some defect in placenta or there's some pathology of placenta, this fetus birth weight will be decreased. We call it intrauterine growth restriction. Okay, if the birth weight of the fetus is more than 4 kgs, we usually call it macrosomia. Macrosomia, right? Macrosomia means the body of the fetus is very large as compared to all other children of its age. Okay, see, so till now in neonatal parameters we have discussed length is usually 50 centimeters, and we talked about birth weight, which is normally 2.5 to 4 kgs. So we discussed that if the child's birth weight is less than 2.5 kgs, we should think in terms of IUGR, and the cause for IUGR is chronic placental insufficiency, right? If the birth weight of the child is more than 4 kgs, we should think in terms of macrosomia. So this large baby. So there can be many causes for macrosomia also, but for Krok, the most important cause related to Krok is gestational diabetes mellitus. Gestational diabetes mellitus, right? We have talked in obstetrics module also about this gestational diabetes mellitus, but I'll quickly revise it. Okay, here, so what is gestational diabetes mellitus? Is diabetes mellitus, that is hyperglycemia, develops in a pregnant female after 24 weeks of gestation. So during the third trimester, okay, if a normoglycemic female, she develops hyperglycemia, we call it gestational diabetes mellitus. And for investigation of gestational diabetes mellitus, this is important. Okay, we should do glucose tolerance test. Glucose tolerance test. Okay, what's there in tolerance test is we usually check fasting blood glucose in the patient, in the female, pregnant female, and then we give 75 grams of glucose orally, and then we check blood glucose in the female again. Okay, then we check blood glucose after 1 hour, after 2 hours we check blood glucose. Okay, if the values are high, then we can make the diagnosis of gestational diabetes mellitus. Gestational diabetes mellitus. And for the treatment of gestational diabetes mellitus we use insulin. So any pregnant female with gestational diabetes mellitus we should treat with insulin, so we don't go for oral hypoglycemic drugs because they can be teratogenic. Okay, so that's why we use insulin only. So what are the complications of gestational diabetes mellitus is? For our Krok question, so we have discussed this macrosomia, right? So why this macrosomia is a problem? See, the developing child has to come through normal vaginal tract, right? So if the child is big, if the fetus is big, so there can be increased risk for C-section. Okay, there can be some delivery complications, like there can increased need for episiotomy, like this. Okay, there can be polyhydramnios also. Okay, there can be neonatal hypoglycemia risk. Okay, so there can be numerous complications of gestational diabetes mellitus. That's why we treat it, and before treatment we have to diagnose the condition. So we usually use glucose tolerance test for this purpose. Okay, so just remember, if the body weight is more, then we call it macrosomia. If the body weight of the fetus is more than 4 kgs, we call it macrosomia. The most common reason is gestational diabetes mellitus. For the diagnosis we use glucose tolerance test, and for treatment we go for insulin. Okay, then other neonatal parameters are respiratory rate. Okay, so if the normal respiratory rate of any fetus is 40 to 60 per minute, right? So if this respiratory rate is decreased in a preterm baby, so what is a preterm is? So term gestation we usually call, I told you the term gestation is 37 to 42 weeks, right? So any child delivering before 37 weeks of gestation we call it preterm. So in any preterm child, if there's a respiratory rate decreased, we should think suggestive of neonatal respiratory distress syndrome or hyaline membrane disease. Okay, so this is known as neonatal respiratory distress syndrome or hyaline membrane disease. So this is same thing, hyaline membrane disease. Okay, so let us discuss why this disease develops. Okay, so let us discuss about pathology. See, so in any human being, okay, even in childs, we need surfactant to breathe. So why do we need surfactant to breathe is, see, this is alveoli, we all know this. So what is the function of alveoli? It keeps alveoli open. So surfactant keeps alveoli open, right? So in fetus, this surfactant is usually produced in the lungs by 35 weeks of gestation. If there's preterm delivery, so in those children there will be insufficient surfactant present in lungs, right? So there will be neonatal respiratory distress syndrome or hyaline membrane disease, right? So I hope you must have understood the reason for neonatal respiratory distress syndrome in preterms. Okay, this is because of decreased insufficient surfactant. Right. So in all of the preterm babies, there's increased risk for neonatal respiratory distress syndrome. So if you like, if you got a pregnant female, okay, if you got a pregnant female at 32 weeks of gestation, and she is about to deliver, so how can you prevent prophylaxis of hyaline membrane diseases? By giving IV steroids to mother. IV steroids to mother. Okay. So for prophylaxis of hyaline membrane disease, you can give IV steroids to mother. Okay, which IV steroids we can use? We can use dexamethasone. I'll tell you the dose also. Okay, dexamethasone 16 mg every 12 hours for 2 days. Or we can use, so either of these, betamethasone, so 12 mg every 24 hours for 2 days. So the main thing is, for prophylaxis of hyaline membrane disease, we use IV steroids in mother. So what will these steroids do is, they will stimulate the production of surfactant in the child. Okay, let's say you couldn't produce, like, you gave steroids to the patient, okay, or you couldn't give steroids because there was no time at the time of delivery. Okay, so for treatment of hyaline membrane disease, you should give artificial surfactant to the patient, right? Because there's not enough surfactant in the children lung, okay, in the child's lung. So you will give artificial surfactant. How will you deliver this surfactant? Is intratracheally. Intratracheally. So you will give intratracheally artificial surfactant within 15 minutes of birth. Within 15 minutes of birth. Okay, so by this way you'll give a surfactant to the patient, to the child, okay, of HMD, hyaline membrane disease, or neonatal respiratory distress syndrome. Okay, apart from this, after delivering of surfactant intratracheally, you can give oxygen support also. So for oxygen support, we usually go for CPAP. What is CPAP? Is continuous positive airway pressure. So write it here, continuous positive airway pressure. Airway pressure. Right. In the Krok question, they don't write CPAP or they don't write oxygen support. They usually write artificial lung ventilation for this word. Lung ventilation. Okay, so I'll quickly revise this. Neonatal respiratory distress syndrome is, this is usually seen in preterm babies, usually delivering before 35 weeks of gestation, and this is due to insufficient surfactant. Right. If the child is not able to breathe, okay, if the child is not breathing and you are suspecting this neonatal respiratory distress syndrome, you can order a chest x-ray. In the chest x-ray, there will be hazy lung fields. Okay, I'll show you this image. Okay, so in this image you can see there's no proper pneumatization. So there's less air in the lungs, right? Because the air makes the air makes this lung fields blackish. Okay, so there's a decreased blackish, these things. Okay, so there's decreased pneumatization, so less pneumatization. Okay, so let's say you have diagnosed a patient of HMD, okay, hyaline membrane disease. For treatment, you usually go for intratracheal surfactant, and you can also give CPAP, that is artificial lung ventilation. Okay, for prophylaxis, you should use steroids, and the steroids we talked about, dexamethasone and betamethasone. Okay, so this was about respiratory distress syndrome in preterm babies. Okay, preterm babies. if this respiratory rate is decreased in a term baby, so we usually call it neonatal asphyxia. Asphyxia. Okay, this question also they have asked. This question they have asked in Krok question and the Krok 2. Okay. Then, so till now we have discussed about three parameters: length, birth weight, and respiratory rate. Now move on to most important and last parameter is heart rate. So the normal heart rate for any neonate or in fetus also, it is 110 to 170 beats per minute. Okay, so let's say if this heart rate is less than 110 or less than 100, we usually call it distress. Okay, so distress. So if this heart rate is decreased in a fetus means intrauterine. Okay, so this fetal distress we discussed in obstetrics also. Okay, if there's intrauterine fetal distress present, fetal distress means heart rate less than 100 or 110. Okay, so if there's fetal distress present, intrauterine, so you have to take out the baby, right? Because see, if there's distress present in the developing fetus, you have to deliver it immediately, because so that you can treat the patient, treat the child. Okay, so if there's fetal distress, you will look at cervix. If there's open cervix, you will do forceps operation. So you will forceps operation. So your main aim in fetal distress is just take out the baby as soon as possible. So okay, so you'll try to take out baby quickly. So if cervix is open, you'll do normal vaginal delivery assisted with forceps operation, right? If there's cervix closed, so now you cannot, like, you don't have time to initiate normal vaginal delivery, so you'll do C-section. Good. If this distress is present in a neonate, call it neonatal distress, right? Neonatal distress. And all of these children, okay, in those children we have to initiate neonatal resuscitation. Okay, so we have to initiate neonatal resuscitation. Okay, so before starting neonatal resuscitation, I'll tell you some initial steps we take in all of the children. Okay, it doesn't matter like what's their heart rate, what's their respiratory rate. We do initial measures in all of these child. Okay, so just after delivery, firstly we take the child and we do positioning of the child. Then we do suctioning. So we do mouth, suction from mouth, suction from nose. Okay, so suction of mouth followed by nose. Then we do drying of the baby, right? And then we do tactile stimulation. So these initial measures we do in all of the babies. Okay, so just after delivery we have, let's say we have done all these measures, and then we do examination of the child. So in examination, most important thing is we check heart rate. So if there's distress present, we do neonatal resuscitation. But let's say you have checked the heart rate and there's no distress. So let's say child's heart rate is normal. Normal means 110 to 170. So after these initial steps, you have done the examination of the child and the heart rate of the child is normal. Then you start initiate breastfeeding. If everything is fine, just initiate breastfeeding in the child, and that's it. Initiate breastfeeding. Okay, but if the distress is present, take the child for neonatal resuscitation. So what are the steps for neonatal resuscitation is, so after doing all these steps, you have done the primary examination, then you found out that there's a fetal distress present, right? So you have initiated neonatal resuscitation. So the first step for neonatal resuscitation is positive pressure ventilation. So positive pressure ventilation, also known as bag and mask ventilation. So I hope that all of us, all of you guys, okay, you must have studied this neonatal resuscitation for OSCE exams. Okay, so the very first step is PPV. So we do mask and bag and mask ventilation for 30 seconds. Okay, and after 30 seconds we do re-examination of child. So we again check the heart rate. So still the heart rate is less, we can do intubation of the child. Intubation of child plus start chest compressions. So we start CPR. Right, we know the ratio is 3:1. So 3 times chest compression, 1 breath. 3 times chest compression, 1 breath. And we do this for 1 minute. Right. So after doing this intubation and chest compression, we will again do re-examination. Heart rate check. And let's say we are imagining, okay. So let's say still the heart rate is less. So we'll give injection adrenaline, epinephrine or adrenaline, okay. Adrenaline 0.1 to 0.3 mg per kg. Okay, and in most of the cases after this, the heart rate of the child usually becomes in normal range. Okay, so I'll quickly revise this. We talked about neonatal parameters. In neonatal parameters, we talked about length, we talked about body weight. In body weight, if it less than 2.5, we call it IUGR. For IUGR, remember about chronic placental insufficiency. More than 4 kg birth weight, remember about macrosomia, about gestational diabetes mellitus, glucose tolerance test, and insulin its treatment. Okay, we talked about respiratory rate. If it's less in preterm, we should think in terms of neonatal respiratory distress syndrome, right, or hyaline membrane disease. We do chest x-ray and we see hazy lung fields. For treatment, we have talked about intratracheal surfactant. Okay, and we will also do CPAP, oxygen support. For prophylaxis, we talked about steroids. Right. If the respiratory rate is decreased in term babies, we call it neonatal asphyxia. Then we talked about heart rate. So in fetus, if heart rate is decreased, we call it fetal distress. And our main aim to treat fetal distress is to take out the baby so that we can treat the fetus. Okay. If cervix is closed, we do C-section. If cervix is open, we do forceps operation. Okay, all of these questions they have asked in Krok 2 exam. If this heart rate is decreased in a neonate, we usually go for neonatal resuscitation. Okay, so we studied this initial measures, okay, like positioning of the child, sanation of mouth and nose, then this drying of baby to prevent neonatal hypothermia. Then we also do tactile stimulation. Okay, but what if the child is born through meconium stained liquor? So what is a meconium stained liquor is? Right, what is a meconium stained liquor is? See, this amniotic fluid, it is stained with meconium. Okay, meconium is this the first stool passed by child. Okay, This is usually seen in post-term babies. Post-term babies. Okay, this is usually seen in Krok question for telling meconium stained liquor. They can also use pea souped liquor. Okay, and they both mean the same. Okay, because the amniotic fluid, it is greenish in color, and this is because of the meconium. Okay, the important management for pea soaked liquor or meconium stained liquor is sanation of trachea. So you will do suction of mouth and nose, and you will also do suction from trachea or sanation of trachea. Okay, this should be marked as the answer for meconium stained liquor. Okay, so we are done with neonatal parameters. So we talked about respiratory rate. If it is decreased, we call it neonatal respiratory distress syndrome, right? All these things. In neonatal respiratory distress syndrome, one more important thing they talked in May 23 exam was Silverman score. See, you don't need to know about Silverman score because it is very complicated. Okay, this Silverman score. Okay, Silverman score. Just remember 2-3 points about Silverman score is it is used to check the severity of respiratory neonatal distress. Okay, so let's say if a child born to mother has Silverman score 9 out of 10, so 10 is the maximum. So this indicates severe respiratory distress syndrome, and then definitely you have to do this intertracheal surfactant and CPAP. But if the Silverman score is 2 out of 10, so this is mild respiratory distress syndrome. So just remember the Silverman score is used to check this severity of respiratory distress syndrome, and if the score is high, then we call it severe respiratory distress syndrome. If the score is less, then we call it mild respiratory distress syndrome. Okay, so now let's discuss about EPGAR score. EPGAR score. So in most of the pediatric cases or in obstetric cases, we uh, mm, the examiner they mention like EPGAR score at 1 minute is this. EPGAR score at 5 minutes is this, like this. Okay. So what is this EPGAR score? See, so in all of the children, okay, we check EPGAR score at 1 minute and 5 minutes after birth. Okay, what this EPGAR score is, we look for appearance of the child. Appearance means, see, you are looking at the child and the child is completely blue child. Okay, you give 0 score. So in all these 5 parameters of EPGAR score, you can mark 0 score, 1 score, or 2 score. So the maximum score can be 10, and if the score is high, that is 7 to 10, this is normal, right? And if the score is less than 7, this is poor prognosis, right? So the higher the score is, good prognosis of the child is. Okay, 6, right? So the normal EPGAR score is from 7 to 10. So these parameters you have to check in the patient. Okay, in the child. So what are these 5 parameters? I'll show you in the table. See, in the May 23 exam, they have specifically asked you to calculate EPGAR score. Before, in all of the previous year papers, they were usually asking about what can be the cause of this decreased EPGAR score, but now they ask to calculate it. Okay, so in EPGAR score, I told we check for appearance, we check for pulse, we check for grimace. Okay, activity and respiratory effort. See, appearance, we all know that if the child is completely blue, we give 0 point. If there's peripheral cyanosis only present, peripheral cyanosis means there's bluish hands, bluish feet, but there's no blue mouth. Okay, so no central cyanosis is there. Then we give 1 point. If the child is completely pink, we give 2 points. Similarly, pulse. If pulse is absent, 0. If pulse is less than 100, you give 1 point. And if it's more than 100, that it's good pulse. Okay, you give 2 points. Grimace, grimace means reflex. Okay, so you usually put a NG tube on the throat, and you look for some reflexes. Okay, if the reflex is good, you give 2 points. There's minimal or weak reflex, you give 1 point. And if there's absent or floppy child, no reflex, you'll give 0 point. Similarly, for activity you check for muscle tone. If muscle tone is present, so the child is fully flexed, okay, completely, you give 2 points. But there's minimum flexion, okay, you give 1 point. And absent, so the child is completely extended, you give 0 point. Respiration, we don't check for respiratory rate, we look for respiratory effort. Okay, if the child is vigorously cry, okay, so we give 2 points because the respiratory effort of the child is good. If this respiratory effort is low and irregular, we give 1 point. And if this is absent, we give 0 point. Okay, so higher the score, the good prognosis of the child will be. Okay, and we usually check APGAR score at 1 minute and 5 minutes. And the score should be in increasing order. Let's say at 1 minute, APGAR score of the child was let's say 5 or 6, but at 5 minutes it's 8 or 9. That is good thing. Okay, then we'll move to delivery complications. Delivery complication. Okay, let's say we have delivered a child, and we checked the heart rate of the child, we checked all the neonatal parameters, and they're fine. Okay, then we checked APGAR score. APGAR score is also good. Let's say in our child it's 1 at 1 minute it's 7 8, and at 5 minutes it's 9. Okay, so this is good, right? Let After this we check for delivery complication. So during delivery, there's increased risk for shoulder dystocia. Shoulder dystocia. Okay, what is this shoulder dystocia? Is, let's say you're delivering a child through the normal vaginal tract. Okay, and there's the child has to come through this pelvis. Okay, so pelvis is a bony cavity, right? So if the child has to come through this bony cavity after delivering of head, usually we take out the baby with force. Okay, to deliver it quickly, to prevent from postpartum hemorrhage. So there can be some shoulder dystocia. Shoulder dystocia means there's some damage to brachial plexus. To brachial plexus. Okay, what is the brachial plexus means? I'll quickly try to explain it. This is our spinal cord, right? So we all know in spinal cord we have different segments, right? We have cervical segment, thoracic segment, lumbar segment, coccygeal segment. Okay, like this. So in some cervical segments, this C5 to T1. So these spinal nerves, they innervate upper limbs. Okay, so these nerves, okay, especially C5 to T1, which innervates upper limb, we call it brachial plexus. Brachial plexus, right? So if there's damage of these nerves, okay, any nerves like C5 to T1, these nerves, we call it shoulder dystocia, right? In Krok question, you must have read about Erb's palsy, Klumpke's palsy, about total obstetrical palsy, right? So we are trying to differentiate these. Okay, so I'll make you understand these palsies. Okay, see, we talked that C5, C6, C7, C8, T1. So these nerves, they innervate this upper limb, right? So if there's damage of C5 to T1, uh, let's say we have damage of C5 and C6. So these nerves, they usually innervate this part, this upper part, shoulder part and arm part. Okay, so we call it Erb's palsy. So what is Erb's palsy is, so there's damage of C5 and C6 spinal nerves. Okay, so if there's damage of these upper spinal nerves, there will be decreased movement, okay, or absent movement of shoulder joint, right? There will be decreased movement or absent movement in arm joint also. So there will be no movement in shoulder, there will be no movement in arm, right? But there will be movement present at hand muscles. So hand muscles, okay, these muscles, they will be working properly in Erb's palsy, or there might be mild reduced activity of hand muscles. So the hand of the child will look like there will be no activity in shoulder, no activity in elbow joint, okay, but there will be in hand muscles present. Okay, so we call it Erb's palsy. Understood? Hmm. After Erb's palsy, let's discuss about Klumpke's palsy. Klumpke's palsy. In Klumpke's palsy, this is lower brachial plexus injury. So there's damage to C8 to T1. Or should we diagnose with symptoms? You have to diagnose this with symptoms, okay? So I've just told you in Erb's palsy there's decreased movement in shoulder, in arms, and usually the hand movements they are preserved, okay? So this is, I told you, this is because of C5 C6 damage. So in Krok question they might give it or they might not, okay? For Klumpke's palsy, there's damage of lower brachial plexus injury, okay, C8 or T1. So there will be preserved, so there will be damage of this hand function, okay? So there will be preserved shoulder arm movements but decreased or absent hand sensitivity. So there will be decreased hand sensitivity, there will be absent hand reflexes, okay, hand to mouth reflex, there will be absent grasp reflex. And in Erb's palsy these might be present, okay? In most of the cases this grasp reflex, hand to mouth reflex is present in cases of Erb's palsy, but in case of Klumpke's palsy there will be lower brachial plexus injury. So there will be absent hand sensitivity, absent hand to mouth reflex, and absent grasp reflex, okay? Hmm. In Crow question, they might also write this as inferior-distal obstetrical palsy. Okay. Then this total obstetrical palsy is so I couldn't find much about this total obstetrical palsy, okay, in any textbook, but from the Crow question I've just imagined like this total obstetrical palsy is damage of total brachial plexus. So in one of the question they have given all the signs of total brachial plexus and total obstetrical palsy, and they asked which spinal nerves are involved, and in that question they have marked this C5 to T1. So there's damage of total brachial plexus, okay? So that's why we call it total obstetrical palsy. So in total obstetrical palsy usually there will be no movement at shoulder joint, no sensitivity at arm joint and hand joint, okay? And there will be in Klumpke's palsy there will be hand muscle atrophy also, okay? Hand muscles atrophy also, okay? So this was about delivery complications. After that, let's say there were no complications during delivery in our child. So there were normal parameters, APGAR score was normal, there was no delivery complications. So usually whenever a child comes for general examination, okay, in your OPD, you always check for anthropometric measures. anthropometric. And so we check for anthropometric parameters. Okay, why do we check these anthropometric? Like we all know anthropometric parameters are height, weight, chest circumference, head circumference. Why do we check these anthropometric parameters? Is to check normal development and growth of child Okay, to check for normal development and growth of child, we usually check anthropometric parameters. Okay, and what are these anthropometric parameters? Are height of child, we check for weight of child, we check for chest circumference, head circumference. We also look for secondary sexual characters. What are these secondary sexual characters? Are in females, this is thalak, menak, we talked in gynecology module. In males, there's enlargement of testes. These are the secondary sexual characters. Okay, we check for secondary sexual characters in all adolescents. All adolescents. Adolescents mean children of 10 to 19 years of age, right? So we usually check these secondary sexual characters also in all adolescents. Apart from these, we check for height, weight, check chest circumference, head circumference. Okay, these parameters, these are known as anthropometric parameters. After checking these anthropometric parameters, we usually compare these parameters with the normal range. Okay, firstly I'll tell you these physiometric parameters also. So apart from anthropometric parameters, we check for physiometric parameters also. We try to measure some lung vital capacity also. So this lung vital capacity also we check. And why do we call it physiometric parameters? Are because we are checking some physiology. So we are checking for physiology. Okay, that's why we are naming it as physiometric parameters. And anthropometric parameters are we are checking the measurements. We are taking the measurements of the body. Okay, so that's why anthropometric parameters. Okay, so let's say we have calculated physiometric, anthropometric parameters of any child. Then we do compare it. We compare it with normal parameters. Okay, so we have WHO charts, World Health Organization charts for this thing. So they have made normal charts for every parameter, for height, for age, for length, for age, body weight, for age, for girls and boys. They have made different charts. Okay, so we compare it with that. So after comparing, there can be some deviation to normal activity, right? We call it sigma. So sigma is deviation to normal parameter, right? So I'll give you an example. Is let's say a child, 10-year-old child, okay, male child, has come to your OPD, and you have checked the height of the child, right? And the height of the child is 167 centimeters. So you have plotted this height on a WHO chart, and according to that chart, there should be height of this 10-year-old male should be 170 centimeter. So this height is not like the child is not dwarf. Okay, there's just like there's some deviation to normal parameter, right? So we call it sigma. So there's some sigma deviation of minus. So sigma will be minus 0.2, for example. So there's some deviation, and minus sign indicates that this is decreased to the normal parameter. Okay, so if in some question you get height sigma, this weight sigma. Okay, so these are the deviation. So after comparing it, we usually classify child is we into harmonious. So the growth and development of the child can be harmonious, disharmonious, and severely disharmonious. Okay, disharmonious. So after comparing the child's parameter, you usually find out you usually calculate sigma, right? So after calculating sigma, you usually check for harmonious growth, disharmonious growth, or severely. So what is the growth pattern of the child? Okay, so if these sigma values are between -1 to +1, we call it harmonious growth, right? If this sigma value is -2 to +2, that is there's more deviation to the normal parameters, we call it disharmonious, right? And if it's -3 to +3, so there so the deviation is very big, we call it severely disharmonious or markedly disharmonious. Disharmonious. So this harmonious growth, disharmonious growth, they've asked for in Krok 2 questions. Okay. So just remember, if the sigma values are between -1 to +1, then we call it harmonious growth. If it is between -2 to +2, then we call it disharmonious growth. And if it is +3 to -3, then we call it severely disharmonious growth. Okay. So after this growth and development, let us see this health groups also here. Okay. So how, how do we get the questions on health group? Okay, so usually the questions for health group are, they will give like a patient is suffered from this condition, the patient got ill 4 to 5 times in a year, tell the health group of the patient. Okay, so there are 5 health groups: first, second, third, fourth and fifth health group. So there are 5 health groups in which we can classify any patient. Okay, so let's say we are talking about pediatrics. Okay, so now let's say any child who has come to you. Okay, and the child didn't get sick at all during the complete year. Okay, or there was acute infections, right? So we usually see in the child, like the child is suffering from upper respiratory tract infection or some acute viral infections. Okay, so there's history of some acute infections, but the number of acute infections were less than 4 in a year. So we classify that child into first health group. So first health group is usually healthy children, right? So yes, they will give sigma values in all of the questions. Okay. Hmm. So first health group means healthy child. So the healthy child means the child didn't get sick at all, or there were some acute infections, but the number were less than 4 per year. Okay. In second health group, there were history of acute infections, but more than 4. In third, fourth, and fifth, they will give chronic infection in child. So let's say a child is suffering from chronic bronchitis. So child must come into third, fourth, or fifth health group, right? What is the difference between third, fourth, and fifth health group is, in all of these health groups, the child must be suffering from chronic infection, but in third health group, the child suffering from chronic infection is in compensated state. So the child's body is compensating all the effects of that disease on the body, right? In fourth is subcompensated. Subcompensated. And in fifth it's decompensated state. Okay. So for Krok, just remember these 3 health groups, they are more than enough. Okay, first, second, and third. So usually they will give a child or any patient with acute infections less than 4 times a year. Then you call it first health group. If the acute infection history is more than for 4 times in a year. Right? If any person is getting ill for more than 4 times in a year because of acute infections, right? We call it second health group. If it's chronic disease, then we call it third, fourth, or fifth health group, because depending on the compensation level. Okay. So till now we have done with neonatal parameters, health groups, anthropometric measurement parameters, physiometric parameters, okay, and this delivery complication and EBCAR score. Any doubts still here? Okay, these compensations they don't ask in Krok because this is little bit complicated. So this things, okay, these health groups they are from the hygiene subject, okay, and they've never mentioned them completely. This compensated state, subcompensated, and decompensated state. So most probably they won't ask about this thing. Hmm. Okay. Any more doubts? Cool. Then let's move on some small topic first. Okay. So we have got some question on aspirin also. So usually we don't use aspirin in children. Okay, we all know this thing that we don't use aspirin in children, right? And why don't we use aspirin in children is there are some side effects of usage of aspirin in children especially. And the two most important side effects we should be knowing is first one is Ray's syndrome. Ray's syndrome. And the second one is acute epidermal necrolysis. Epidermal necrolysis. Okay, see, we shouldn't use aspirin in children because it can cause Ray's syndrome or acute epidermal necrolysis. There can be more complication, more side effects also. But for Krok, we are talking specially for Krok. That's why I've taken only these two side effects. Okay, what is Ray's syndrome is because of aspirin. There's damage to brain and damage to liver. That's why we don't use it, right? And sometimes after taking aspirin the child might get some skin rash similar to burns. So in that condition we call it acute epidermal necrolysis. So there's necrolysis of the epidermal layer. Okay, and how does it look like? As you can see that. So this rash looks like burn and it has developed after aspirin, right? That's why we call it acute epidermal necrolysis, and we shouldn't use aspirin in children. There's only indication of aspirin in children is, so we don't use aspirin in children. Okay, there's just single indication where we can use aspirin is this is Kawasaki disease. Kawasaki disease. Okay, so apart from Kawasaki disease, in any condition we never use aspirin in children. Okay. Okay, let us move to pediatric infections. Pediatric infections. So we'll talk about measles, rubella, and mumps. Okay, so these three are the most important pediatric infections. Okay, so before starting these measles, rubella, and mumps, just remember this thing is, so these all are viral infections, right? These all are viral infections. We know this thing. So why this is important to know about a viral infection is all the viral infections or most of the viral infections they have a viral prodrome. Viral prodrome. So what is a viral prodrome is, let's say you get a patient with some clinical symptoms, sign and symptoms. Okay, so how can you differentiate that the patient has a viral infection or bacterial infection? So you look for viral prodrome or bacterial prodrome. So what is the difference between viral prodrome and bacterial prodrome is, usually a viral infection they usually have mild fever in the patient, mild fever, then some coryza like symptoms, runny nose. Okay, so these symptoms, these we know known as viral prodrome. In bacterial prodrome there's usually high grade fevers. Okay, in viral prodrome there's usually mild fever. Okay, so you can remember that measles, rubella, mumps, these all will present with some mild fever in a child. Okay, so let us talk about measles first. measles. See, in measles, the child will present with mild fever, right? Conjunctivitis can be there, coryza, runny nose. These symptoms will be definitely there. Apart from these symptoms, there will be maculopapular rash. Maculopapular rash in the child, right? Apart from maculopapular rash, there can be Koplik spots. Koplik spots. So in Krok question, they usually don't write Koplik spots directly. They'll explain that the child with mild fever, conjunctivitis, coryza, runny nose develop maculopapular rash, and there are some whitish spots, some whitish spots on cheeks. So there's like on the inside part of the cheek, there's usually some whitish spots develop. We call them Koplik spots. Okay, and this is the pathognomic sign for measles. Okay, apart from these, there's no lymph node involvement. Okay, so I'll show you this maculopapular rash. Okay, this is maculopapular rashes. Why do we call it maculopapular rashes? In this rash we have macules and papules. So macules are usually smaller lesions, there's usually larger lesions. So if we get both small and larger lesion, we call it maculopapular rash. Maculopapular rash, right? So in rubella also we get viral prodrome, because this is also a viral infection, right? In this also we get maculopapular rash. But in rubella we also get lymph node enlargement, and usually these are occipital lymph nodes enlargement. There can be posterior auricular lymph nodes enlargement, right? So in patients of measles and rubella, the clinical features will be same. You just have to look for lymph nodes also, right? If the lymph nodes are enlarged, then it should be rubella. Okay. Then talks about mumps. So the only important thing for diagnosis of mumps is there should be some parotid gland enlargement. So any child with parotid gland enlargement, you should suspect mumps. Okay, so any child with parotid gland enlargement, just suspect mumps. Okay, so these three are the main pediatric infections we should know about: measles, mumps, and rubella. Right. So apart from these infections, we have talked about pneumonia, about bronchiolitis, right? In pulmonology module. Okay. So after pediatric infection, let us discuss about torch infections also here. So what a torch infection is? See, let's say a pregnant female got some infection. Okay, and these infections are transmitted through placenta to developing fetus. If there will be some viral or bacterial infection or parasitic infection in a fetus, it can cause teratogenic effects. So there will be some congenital defects in the patient, in the child. Okay, right? So that's why we screen all the female. We do screening of all pregnant female for this torch infection. Torch infection means, so if there's some toxoplasmosis infection, rubella, CMV, herpes. So we check in all of the pregnant females, we look for some infections, okay, for toxoplasmosis, rubella, herpes, CMV. O means others, right? So there are some other infections also we have to screen in pregnant female. So for screening, we check for IgM antibodies and IgG. So if IgM antibodies are increased, that means there is some active infection in the patient, and the patient might need abortion. Because if the patient will continue this pregnancy, there will be increased risk for congenital defect, right? So let's say the patient didn't go under some screening examination, and then the patient developed some infection, and the child is delivered, right? So there will be some congenital defects, right? So if a child is born to a mother with toxoplasmosis, so there will be congenital toxoplasmosis syndrome, right? So in congenital toxoplasmosis, we'll get some sign and symptoms in a baby, so that we can diagnose the mother was ill with toxoplasmosis during pregnancy, right? So for children of congenital toxoplasmosis, there will be chorioretinitis in the children. Chorioretinitis in the children. There will be intracranial calcification, and there will be hydrocephalus. Okay, so I'll make you remember these silent symptoms. Okay, in congenital rubella, in congenital, let's discuss CMV first. Okay, rubella. So I'll give you a mnemonic. Okay, in patients of congenital CMV, there will be signs of CMV. CMV means chorioretinitis. There will be microcephaly, and there will be periventricular calcification. See, in Krok question, they'll directly give you these signs and symptoms in a baby, and they'll ask you what is the diagnosis. So you have to tell this is congenital toxoplasmosis, congenital CMV. Okay, and how to remember this is, see, congenital toxoplasmosis you can remember by chorioretinitis. So chorioretinitis, so it's present in CMV also. So okay, there are some intracranial calcification, periventricular calcification in CMV and toxoplasmosis both. But this toxoplasmosis, this is a big word, right? It's a big word. So that's why hydrocephalus. So there will be macrocephaly in the patient. That's why hydrocephalus. And then CMV is a small word. That's why microcephaly is present in a child. Okay. Apart from these two infections, we should also know about congenital rubella syndrome, right? So these are the three main congenital torch infection we should know. So in congenital rubella syndrome, you can remember it by CDC. CDC means there's cataract, there's deafness, and there's congenital heart defect. So to tell this congenital heart defect, they can talk about VSD, ASD. Okay, some congenital heart defect, ventricular septal defect, right? Ventricular septal defect. So just remember congenital rubella syndrome, CDC, cataract, deafness, and some congenital heart defect. For CMV, just remember CMV, C means chorioretinitis, M means microcephaly, and V means periventricular. Okay, so I'm using this words V here is periventricular calcification. For congenital toxoplasmosis, also there can be chorioretinitis, intracranial calcification, but this word toxoplasmosis is big, that's why hydrocephalus. Okay, so I hope this will help you. Okay, so we are done with torch infections also. So after this pediatric infection, let us discuss some pediatric GI pathology also. GI pathology also. So the most important for our Krok to exam is intersusception, or they call it invagination. Okay. So what is intersusception or invagination? Okay, let's say we have this intestine, okay, the part of intestine. Let's say anyhow this part of intestine is moved into each other. Okay, so we call it intersusception. So how it will look like is like this. Okay, we call it intersusception or invagination, same thing. or invagination. Okay, before starting about clinical signs and symptoms, I'll try to explain this here. Okay, in this image you can see there's one part of bowel has entered into another part of bowel. Okay, so we call it intersusception. So the clinical presentation of child of intersusception will be the child is usually 6 to 9 months of age. Why this age is? See, so before we ask the mother to do exclusive breastfeeding till 6 months of age. After 6 months of child, we usually go for weaning. What is weaning is we give some soft food to the baby, right? And during this period of weaning, this increased risk for intersusception, right? So in intersusception, the mother will say that I have noticed per rectum bleed. So per rectum bleed of her child. Okay, so mother will complain that she has noticed some blood from rectal area of her child. Okay, so this will the main complaint, and you should suspect in this age. Okay, this should be intersusception. For treatment, for diagnosis confirmation, investigation, sorry, you can do barium enema, right? You can do barium enema, you can do ultrasound. So there are many things, there are many ways to diagnose it. Okay, for treatment you usually go for air enema. And for prophylaxis, this prophylaxis thing they've asked in Krok, right? So for prophylaxis, their mother should follow proper diet regime. Okay, this question they have asked. So a child treated with air enema, okay, or by any way, a child was having intersusception. Now he is treated. What all guidelines, okay, what all recommendation we should give to the mother, okay, and the mother should follow proper diet regime. Okay. So after intersusception, let us discuss about celiac disease also here. Celiac disease or gluten intolerance. Okay, see, there's some children, okay, which are intolerance. So whenever they are exposed to some food with gluten, okay, they develop some clinical features like foul smelling stools. Okay, there will be diarrhea in the child. Okay, weight loss will be there. So these are the clinical presentation uh, of a child with celiac disease. Okay, what are the products with gluten, which we call, which we remember by bro. Okay, so the barley, rye, oats, wheat. Okay, and in Crow question they have mentioned semolina. See, in any child after introduction of these products, food products, if the child develops these clinical features, foul smelling stools, diarrhea, weight loss, we call it celiac disease, right? Because the child is not able to digest these gluten products. Okay, and for the treatment of this or the management of this condition, we usually recommend gluten-free diet. Gluten-free diet lifelong. Okay, we usually recommend to take gluten-free diet, because if there will be no gluten in the patient's diet, then there will be no symptoms at all. Okay, so after this GIT part, would you send this pediatrics? Yes. See, after this pediatric GI pathology, celiac disease, and intersusception, let us talk about neonatal jaundice. Neonatal jaundice. Okay, see. We all know what jaundice is, right? So jaundice is increased serum bilirubin, right? So jaundice is increased serum bilirubin, right? So before starting talking about neonatal jaundice, let us discuss the pathway, okay, or metabolism of bilirubin. So why we are talking about metabolism of bilirubin is this is important for pediatrics as well as for surgery. Okay, that's why I'm going to discuss about metabolism of bilirubin. See, when so we all know in RBCs we have hemoglobin, right? So whenever this RBC, there's degradation of RBC, okay, or hemolysis. So whenever this RBC breaks down, there's a release of hemoglobin in blood, and this is converted to the part of the hemoglobin, it is converted to unconjugated bilirubin. Unconjugated bilirubin. Okay. After this unconjugated bilirubin is present in the blood, in the serum, right? It goes to liver. In the liver, there's conjugation process, and after this conjugation process, this bilirubin becomes conjugated bilirubin. Conjugated bilirubin. Okay, this conjugated bilirubin, this is excreted in intestines via biliary tract. So, in pediatrics, now we will mainly talk about this hemolysis thing, okay, and increase of unconjugated bilirubin. But in wait, yes, but in case of surgery, there can be some liver issues also, where we will talk about hepatic cirrhosis also. Okay, there can be some biliary obstruction like chronic calculus cholecystitis. So there can be conjugated hyperbilirubinemia also. Okay, so uh, this is important to understand the metabolism of bilirubin so that you can easily understand what can be the cause of this unconjugated bilirubin in the patient, what can be the cause of conjugated hyperbilirubinemia in the patient. Okay, this is so we were talking about neonatal jaundice, right? So all of us we know like jaundice is normally present also in the children. Okay, so if this jaundice is physiological, this is usually seen during second to 10th day of life, right? So this neonatal jaundice can be physiological jaundice also during second to 10th day of life, right? And usually there's no need of treatment required. Okay, so no treatment is usually required for neonatal jaundice, physiological, right? But for Krok question, physiological jaundice also they can ask, but they usually focus on pathological jaundice. So what is pathological jaundice is usually this pathological jaundice is present on first day of life, right? And there's very high, very high serum bilirubin level, so that we have to treat this condition aggressively. So treat pathological jaundice properly. Okay, so we have to treat this pathological jaundice. Okay, for Krok 2, there are the three most important causes for this pathological jaundice is RH incompatibility, ABO incompatibility, and cephal hematoma. So we'll talk about cephal hematoma. We'll talk about these one by one. Okay. So let us discuss about RH incompatibility. See, in all of these conditions, there will be increased hemolysis. Okay, there will be increased hemolysis. So because of this increased hemolysis, there will be increased unconjugated bilirubin. Okay, this is the main thing which we usually see in pediatric cases. Okay, so let us talk about RH incompatibility. So what is RH incompatibility? Is, see, RH incompatibility means the blood of two things, like anything, so like two things, they are not compatible to each other, right? So in case of RH incompatibility, what there is, mother is usually RH negative. Okay, what does RH negative means is, so we all know we have RBC, right? We have red blood cell. So on RBC there are multiple antigens, right? There are thousands of antigen present on RBC. So let's say one antigen we call it A, one antigen we call it B. Okay, D, like this. So by this, how which antigen is present, we call our blood groups like A blood group, B blood group, AB blood group. If neither of A and B present, okay, we call it O blood group, right? So if there's presence of D antigen, we call it RH positive patient. Okay, so let's say the mother, a pregnant female, okay, a pregnant female, she is RH negative, and by anyhow her child is RH positive, so fetus is RH positive, right? And let's say this is first pregnancy. So during the complete pregnancy, there will be no exposure of fetal blood to maternal circulation. Okay, but during delivery there will be some fetal blood will go to maternal circulation. So some amount of fetus blood, okay, it will go into maternal circulation, and now the mother's blood will recognize this foreign RH antigen for the first time in her life, and there will be anti-RH antibodies in mother's blood. Okay, let's assume this mother, she is pregnant for second time, so second pregnancy. So during this pregnancy, mother is RH negative only, fetus is RH positive, right? And through placenta, these anti-RH antibodies will go to fetal blood circulation, and it will cause hemolysis. So there will be destruction of RBCs in the fetus, and because of this hemolysis, there will be neonatal jaundice in the patient. Okay, and usually if there's hemolysis, we also call it hemolytic disease of newborn. We call it hemolytic disease, hemolytic disease of newborn. Okay, treatment, they usually ask, treatment is exchange blood transfusion. Blood transfusion. Okay, apart from this RH incompatibility, there can be ABO incompatibility also. ABO incompatibility means, so mother's blood is usually O. Okay, so if O, there will be, the mother's blood will have anti-A antibody and anti-B antibody. Anti-B antibody, right? If in the mother's blood there's no A antigen, no B antigen present, so there will be anti-A, anti-B antibodies. And if this mother, so if this lady is pregnant and the fetus have blood group either A or B, right? So again there will be hemolysis in the patient. Okay, and this hemolysis will be presented with neonatal jaundice in the patient. Okay, so in ABO incompatibility also there can be neonatal jaundice, but this jaundice is usually mild. So there's mild jaundice in newborn, and in most of the cases there's no treatment required. No treatment required. Okay, so that's why this RH incompatibility is more common than this ABO incompatibility, and this we need treatment also. That's why we usually study about RH incompatibility. Okay, what if the mother is RH positive and baby RH negative? Does that cause jaundice? No. If the mother is RH positive and the baby is RH negative, there will be no RH incompatibility. Okay, because in the mother's blood there will be no anti-RH antibodies because her own blood is RH positive, right? So there will be no, if there will be no antibodies in the mother, so there will be no transmission of antibodies. Okay. After this ABO incompatibility, let us talk about cephalohematoma. Cephalohematoma quickly, okay. Cephalohematoma. Okay. So what is cephalohematoma is, this is also a delivery complication. Okay, let's say the head of the fetus is coming out through the pelvic cavity, okay. And during coming out of the pelvic cavity, there's some blood accumulation. Let's say this is the skull of the fetus, this is the skull. Okay, and outside the skull, under the skin, there's some blood accumulation in the fetus. We call it cephalohematoma. Hematoma means there's accumulated blood at some place, and cephalohematoma because this accumulated blood is at head part. Okay, so accumulation, accumulation of blood outside vessels at head part. Okay, we call it cephalohematoma. And if there's accumulated blood outside vessels, there will be hemolysis, and it will cause neonatal jaundice in the patient. Okay, this jaundice is also usually mild jaundice, so with no treatment required. Okay, so I hope this neonatal jaundice is clear. Just remember about RH incompatibility, ABO incompatibility, and cephalohematoma. Okay, RH incompatibility is very important because in that we go for treatment. Okay, this exchange blood transfusion, right? We know we need this treatment. In RH incompatibility, it is usually in the second pregnancy. Mother should be RH negative and fetus should be RH positive only. So not vice versa, okay. If there will be transfer of antibodies through placenta, there will be hemolysis and we'll see neonatal jaundice. Okay. Hmm. So we talked about this hemolytic disease of newborn, right? So if we talked about hemolytic disease of newborn, so why we named it hemolytic disease of newborn is because there's hemolysis in the newborn, right? Don't confuse this disease with hemorrhagic disease of newborn. Hemorrhagic disease of newborn. So I'll just say 2-3 words about this. Is see, hemorrhagic disease of newborn. That means in a newborn there's hemorrhage. There's blood exudation. Okay. So if there's hemorrhage in a newborn, hemorrhage in a newborn, we call it hemorrhagic disease of newborn. So basically mom being negative is the reason for hemolytic disease. Yes, so mother should be negative and child should be positive, right, for developing hemolytic disease of hemolytic disease, right. For hemorrhagic disease, there's hemorrhage in a newborn, and we know most importantly this is because of vitamin K deficiency. Because in mothers so in usually in breast milk also there's no vitamin K in the breast milk, so there's high risk for development of hemorrhagic disease of newborn. For prophylaxis of hemorrhagic disease of newborn, you do injection of vitamin K 1 mg intramuscular in all children. Okay. So now this thing has become mandatory that you give vitamin K injection in all of the children to prevent hemorrhagic disease of newborn. Okay. after this, let us talk about, okay, any doubts still here? So we'll, after this we'll cover like 2 3 smaller topics also. Okay, so after this we'll talk about Henoch-Schönlein purpura. Schönlein purpura. Or HSP. Okay, what is this Henoch-Schönlein purpura? See, this is a type of vasculitis. Okay, so this is a type of vasculitis. Okay, so in patients of Henoch-Schönlein purpura, you'll usually get clinical presentation of some group of symptoms which we can remember by mnemonic PAN. Okay, PAN, right? PAN means there's purpura present, there's this abdominal pain or abdominal bleed present or bleed present. There can be arthralgia in the patient, and there can be some nephritic syndrome symptoms. Okay, yesterday we talked the symptoms for nephritic syndrome is like the patient can have hematuria, cylinder, mild proteinuria, right? So in any patient having purpura and abdominal pain, bleed, or arthralgia, we diagnose that condition with HSP, right? In Krok question, they might name it like IG vasculitis also, or vasculitic purpura. Purpura. So these all things are same: vasculitic purpura, IG vasculitis, HSP, Henoch-Schönlein purpura. These all are same thing, and the symptoms given in the child will be purpura, abdominal pain or bleed, arthralgia, nephritic syndrome, right? So what will be the purpura look like is this, this. Right, so this purpura is usually present on the leg part, okay, on the buttocks, okay. So any child with purpura, abdominal pain or bleed, arthralgia and nephritic syndrome, you should think in terms of Henoch-Schönlein purpura or vasculitic purpura. I hope this HSP is clear, okay. After that, let us discuss about this cystic fibrosis quickly. Cystic fibrosis. Okay. See, cystic fibrosis we also call it mucoviscidosis. Okay, I'll tell you why. Like, just remember the name. You'll make the clinical features by yourself. Okay. See, in cystic fibrosis, there's usually cysts present in pancreas. Okay, and there's usually lung fibrosis, right? So in, and there's involvement of some other organs also, but just remember these things: there's some pancreatic involvement and there's pulmonary involvement, right? So if there will be pancreatic involvement, there will be decreased pancreatic enzymes, so there will be pancreatic insufficiency, right? So child will develop symptoms of malabsorption, diarrhea. There can be constipation also sometimes in the child, right? And in lung, if there's involvement of lungs, there will be recurrent pneumonias in the patient. Okay, so in patients of cystic fibrosis, this involvement of pancreas causing some pancreatic insufficiency in the child. So there will be malabsorption, diarrhea, constipation. The involvement of lung will cause recurrent pneumonia in the child. Okay, why do we get these symptoms in the patient of cystic fibrosis? Is, see, in cystic fibrosis there will be thick secretions, all the secretions of the body, okay, like let's say the mucus secretion in trachea, the pancreatic secretion, they are very thick, okay, and they will cause obstruction, okay, at different places. So if there will be obstruction, it will cause recurrent pneumonias, because all of your mucus, okay, it won't come out and goes into esophagus, which is normally present. So if the mucus is very thick and there and the child is unable to take it out, right, so there will be bacterial proliferation there, and it will cause recurrent pneumonias in the patient, okay. And because of this pancreatic causes, we have already talked. For diagnosis, you will do sweat chloride test. So you will check the level of chloride in sweat, okay, and it will be increased. And usually in our Krok question, it will get 80 millimole per liters of chloride in sweat, okay. This will be the cystic fibrosis. Okay, I hope like I have covered 90-95% of all pediatric questions, all pediatric important topics. Okay, what hemorrhagic purpura? I guess this hemorrhagic purpura and this HSP, all they have named it differently. Okay, but this whole thing is all will have same clinical presentation. Okay, so they might change the name. So somewhere the real name of this thing is Henox colon purpura. Okay, so in Krok question they might write it as vasculitic purpura or hemorrhagic purpura or IgA vasculitis, but they all mean same. Okay, so I hope this lecture is beneficial for you guys, and best of luck for the exam. Okay, thank you. Any doubts? Doubts. Welcome. Okay, then we'll finish.